Hello, my name is Dr. Ominda, and I'm going to discuss the joints of the vertebral arches, okay, in the lecture series on the back. So we have the zygapophyseal joints, which are the facet joints. Zygapophyseal joints are plain synovial joints formed by superior and inferior articular processes of adjacent vertebra. So, like any other synovial joint, they have a capsule, and this is usually thin and loose in the cervical region to allow movement, and this capsule is attached to the margins of articular surfaces. What may ensure stability of the zygapophyseal joints? We have the accessory ligaments. These are the ligamentum flava that unite the laminae, the intertransverse ligaments that unite transverse processes of adjacent successive vertebra, and the interspinous and supraspinous ligaments of the spinous processes. Zygapophyseal joints allow gliding movement. So the shape and disposition of the articular surfaces determine the type of movement, and the size of the IV disc in relation to the vertebral body size will determine the range of movement. So, for example, in the cervical region, the IV discs are bigger than the size of the vertebral body, and that means the range of movement is higher. Okay, in lumbar and cervical region, the articular surfaces are nearly horizontally oriented, therefore they allow flexion and extension and limit rotation, while in thoracic region they are vertically oriented and allow only rotatory movement with limited flexion and extension. So the zygapophyseal joints usually bear some weight in the cervical and lumbar region during lateral flexion, and the joints are innervated by posterior rami of the spinal nerves. So this just shows you the zygapophyseal joints, okay? And this is what happens during flexion, and this is what happens during extension. They overlap. What are the applied aspects if you have disease in the zygapophyseal joints? Remember, these joints are close to intervertebral foramina that are transmitting spinal nerves. So like in aging, you'll have spurs that form, the osteophytes that form in osteoarthritis can compress the spinal nerves, leading to pain in the distribution of the area of the spinal nerve following the patterns of the dermatome. And pain causes muscles to tense, leading to spasms. And these are mainly derived from the associated myotomes. What is a myotome? They are muscle groups that are innervated by a single spinal nerve. So what are these accessory ligaments of the intervertebral joints? We have ligamentum flavum that unite two adjacent lamina. These are usually broad yellow and strong elastic tissue that extend from lamina above to lamina below on both sides. And then the regional differences, you find that the ligamentum flavum in cervical region is thin, and as you go downwards, it becomes thick, and they usually resist separation of the lamina by arresting abrupt flexion of the vertebral column. So ligamentum flavum arrests abrupt flexion of the vertebral column, and they also help to preserve the curvatures of the vertebral column, as well as assist in straightening the column after flexion. So after flexion of the vertebral column, the ligamentum flavum can help to straighten the column. So this is the ligamentum flavum uniting the lamina of two adjacent vertebrae. This is your ligamentum flavum. This is the laminae being united by ligamentum flavum. We have interspinous ligaments between two spinous processes. They are weak and membranous and attach at the root to the apex of each process. Then we also have supraspinous ligaments. These are strong and fibrous cord-like ligaments. Interspinous are actually membranous and weak. Supraspinous are strong and fibrous. And they usually connect the apices of the tips of the spinous processes from C7 to the sacrum. Above C7, C1 to C7, the apices of the spinous processes are connected by the nuchal ligament. Nuchal ligament is a strong median band which is fibroelastic, and it extends from occipital protuberance downwards to the spinous processes of the cervical vertebra. So this supraspinous ligament from C7 to sacrum and upwards, it extends as nuchal ligament, which is from external occipital protuberance up to the spinous processes of cervical vertebra. So because of short C3 to C5 spinous processes, the nuchal ligament substitutes for bone, in providing muscular attachment. So it helps in muscle attachment. Remember, C3 to C5 have short spinous processes. So again, this is just to show you the intertransverse ligament between transverse processes, the interspinous from the root to the apices of the spinous processes. Then this is supraspinous, and above C7, you form your nuchal ligament, extending from the external occipital protuberance downwards to the posterior margin of the foramen magnum up to C1 to C7. And remember, the spinous processes of C3 to C5 are very short, therefore this nuchal ligament also aids in muscle attachment. Look at the intertransverse ligaments connecting transverse processes of adjacent vertebrae. Look at the ligamentous levum there connecting laminae of adjacent vertebrae, is usually strong, elastic, and yellow. The intertransverse process contains scattered fibers in the cervical region, so it's very thin. And as you go downwards in the thoracic, it becomes cord-like and back to thin membranous within the lumbar region. Then we discuss the craniovertebral joints. Okay, these are synovial joints with no IV discs in between them, and they have a wider range of movements. We have two types: atlanto-occipital between the atlas and the occipital condyles, and atlanto-axis between the atlas and the dens of the axis. Atlanto-occipital between superior articular surfaces of the lateral masses of the atlas and the occipital condyles. Okay, so you have occipital condyles and the atlas. This is your atlas, this is the occipital condyles of the skull. So usually they permit head nodding for the yes movement, neck flexion. When you ask the question and you answer yes, you flex and extend your neck. That's occurring at the atlanto-occipital joint, and it permits sideways tilting of the head, as well as the main movement is flexion, but you can have some lateral bending and rotation. It's a condylar type of synovial joint and has a loose and thin articular capsule. So this is your atlanto-occipital joint. Okay, so the cranium and C1 are connected by atlanto-occipital membrane. They are connected by atlanto-occipital membrane. So this is your posterior atlanto-occipital membrane. Okay, posterior atlanto-occipital membrane, and this is anterior atlanto-occipital membrane. These usually extend from posterior arcs of C1 to anterior and posterior margins of foramen magnum. The anterior membrane is broad and densely woven, so these membranes prevent excessive movement of the atlanto-occipital joint. Remember, this is your C2 vertebra, this is the dens, this is C2. C1 is here, it has been resected. This is your atlas here, and this is anterior atlanto-occipital, and anterior atlanto-occipital and posterior atlanto-occipital membrane. Then we go to the atlanto-axial joint. It's also part of the craniovertebral joint. So we have three surfaces of articulation. So this is your atlas and this is your axis. So you have this part where you articulate between you have the median joint and the lateral joint. So we start with the lateral joints. There are two on the right and left side. So between the lateral masses of C1 and C2, and there you form the gliding part of the synovial joints. So the lateral masses of C1 and C2 form gliding synovial joint, and then you have median atlanto-occipital joint between the dens of C2 and the anterior arc of atlas, and the socket is completed posteriorly by the transverse ligament of atlas. So this atlanto-axial joint allows the no movement, side-to-side movement. So the cranium and C1 are able to rotate on C2. So C2 is the pivot. So the cranium, skull, and C1 will rotate over the dens. So during rotation, the pivot of the dens is the axis, and the socket is formed anteriorly by anterior arc of atlas and posteriorly by the transverse ligament of atlas running between the right and left lateral masses of the atlas. So this is the transverse ligament of atlas. It's a strong band that extends between the two tubercles and the medial aspects of the lateral masses of the atlas, and you have superior and inferior longitudinal bands. So superior longitudinal bands vertically pass from the transverse ligament, okay, this is your transverse ligament. So from the transverse ligament superiorly, you have your superior longitudinal band, and as you go inferiorly to C2, you have your inferior longitudinal band. So together with the transverse ligament, you form a crucifix, a cross, and that is why we call it the cruciate ligament. So this is your cruciate ligament formed by transverse ligament, this transverse ligament, and when you have a band that will go superiorly to the occipital bone and inferiorly to the body of C2. So this is your cruciate ligament. Then we have alar ligaments. Okay, alar ligaments. This is your alar ligament here. So from the sides of the dens, you can see the dens is here, the dens of C2. From the sides of the dens, the alar ligament goes to the lateral margins of foramen magnum. Okay, and these are usually short rounded cords that attach the cranium to C1 vertebra. So they act as check ligaments, really. They prevent excessive rotation. Alar ligaments are check ligaments that prevent excessive rotation. They run from lateral surface of the dens to the margins of the foramen magnum. Then we go to the tectorial membrane. This is your tectorial membrane in pink, in purple. This is tectorial membrane. Okay, remember these are your vertebral bodies: anterior longitudinal ligament, posterior longitudinal ligament, and superiorly it continues at the tectorial membrane. The tectorial membrane is a strong superior continuation of the posterior longitudinal ligament. It passes across the median atlanto-occipital joint. Remember, median atlanto-occipital joint is between the anterior arc of atlas and the dens of the axis. So it passes across this median atlanto-occipital joint through the foramen magnum to central floor of the cranial cavity. So it runs from the body of C2, so the body of axis, to internal surface of occipital bone. Usually it covers the alar and the transverse ligament. This is the transverse ligament. Okay, so it has been covered by the tectorial membrane. Again, posterior longitudinal ligament continuing upwards as the tectorial membrane from body of C2 to inner part of the occipital bone. This is the apical ligament from the apex of dens to the tip or anterior border of the foramen magnum. This is the anterior atlanto-occipital membrane, and your posterior atlanto-occipital membrane is here. This is your tectorial membrane. Okay, so basically this is anterior arc of atlas. This is the dens. Again, tectorial membrane is here, posterior longitudinal ligament, anterior longitudinal ligament, apical ligament, posterior atlanto-occipital membrane, and anterior atlanto-occipital membrane. So what are the applied aspects? We've talked about fracture of the dens, which can fracture at different parts. Yeah, you can have fracture at the base, which is the commonest, but you can also have an unstable fracture which fails to unite. Remember, the transverse ligament of atlas can transpose in between the fractured segments. So if you fracture here, the transverse ligament can come and separate the dens. Therefore, the dens no longer gets blood supply. Therefore, you end up getting a vascular necrosis of the dens. You can have fracture of vertebral bodies inferior to the base of the dens, and that can heal more readily because it retains the blood supply. So the dens fractures at different places due to abnormal ossification pattern. So if you fracture here, this part continues to get blood supply, but this one may undergo a vascular necrosis. You can rupture the transverse ligament of atlas. Remember, it holds the dens onto the anterior arc of the atlas. So if you rupture the ligament, the dens is set free. So you can have subluxation or dislocation of the joint. The dens moves posteriorly and compresses the spinal cord, leading to paralysis of all the four limbs. And because it's up there near the brainstem, it can lead to death when you compress the medulla oblongata, which holds the vital centers. Then you can have softening of the transverse ligament in connective tissue disorders, and patients with Down syndrome or subjects with Down syndrome actually have laxity of this transverse ligament of dens or agenesis of the transverse ligament of dens, and this is very risky because of compression of the spinal cord. The alar ligaments can rupture because they are actually weaker and usually due to flexion or extension of the head. Then you can compress